Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. We are at the 171st episode of the Codecast today, and it is the last day of January 26, 2021, which means we are at Top 10 Tuesday. So what I want to do today is our topic is going to be the E&M 2021 Top 10 Questions that Need Clarifications. I have taught so many of the 2021 E&M webinars, webcasts, presentations, also given some things to the local chapters of AAPC, AHEMA, etc. And I'm getting a flood of questions after the fact. So a lot of confusion still, which I kind of thought there would be between data points, medical decision-making, and time. So I really wanted to just give you some updates and understanding of some of the rules and guidelines that you may be thinking about yourself or may not have thought about before, but I think it needs to be said. And so this is the good time to do it. Now, when I do Top 10 Tuesday, I usually have 10 points to make. I'm probably going to make a lot more than 10 points. This is going to be a longer episode, so I hope that you're sitting back or you have your headphones on in your office as you're doing your work, and hope you find this helpful. First of all, the Codecast podcast is also brought to you today by the Cardiac Rhythm Management Coder by MedLearn Publishing, a one-stop resource for safeguarding your CRM, EP revenues, and compliance. The Cardiac Rhythm Management Coder and EP procedures generate substantial revenue for both hospitals and physician practices, but reimbursements can be elusive due to low coding accuracy rates, inconsistent and high technically challenging services, and also sometimes the documentation can be a problem to figure out. You can order the CRM coding tool at www.shop.medlearn.com and find the CRM coder. Okay, so let's take a look today at what we're going to do here. And oh my goodness, there has been so much information, so many questions that have been asked. And I don't know about you, but I'm getting the same question asked over and over and over again, just different ways. And so hopefully you won't find some of this, duplicative, but there is a lot of duplication when it comes to some of the questions. But I'll do my best to try to not only cite you on where some of the information is, but I'm also giving you some of the things that have come up in the CPT Assistant, as they had some insight as to some of the things when it comes to time as well. Okay, so here's some of the things that have come up. First of all, question number 1, if I order an MRI at a visit on November 10th and review it with the patient at a follow-up visit on November 27th, do I count the order on the 10th and the review on the 27th? We did not bill for the MRI interpretation. So first of all, since you didn't bill for the MRI or the interpretation, then you get to count it in your data points, okay? And that's what the question is about. But you only count it once, and that is the date of the order with the face-to-face visit, because CPT, the E&M guidelines on page 14, under medical decision-making, and I'll quote, it states, ordering a test is included in the category of test results, and the review of the test result is part of the encounter, not a subsequent encounter. So I don't think it's fair, but that is the rule. Basically, when you order it, that's also inclusive of you also giving the test result to the patient at a different encounter. And so try not to double dip on that. Question 2, in a cardiology practice, what if my cardiology partner did the official echo report and billed for it, but then I see the patient and view the echo? Can I count that as an independent interpretation? The answer is no. If you're the same specialty partner in your practice and you reported the professional component in the practice or even the technical, do not credit an independent interpretation when you see the patient. What the independent interpretation is that means that the patient brought records to you or records were sent to you from an outside source that your physician did not order the test and did not review the test, and nobody in your practice also reviewed the test. Same thing when it comes to lab results. One of the questions here, and this is number 3, what about lab results? I was away on vacation and my partner saw one of my patients and ordered labs. I saw the patient the next week and reviewed the results. Can I credit the review? If you're in the same specialty, you're considered a single physician If of a different specialty, then it's maybe, yes, I have a lot of large groups who are clients. And for example, they have an orthopedic physician and they have cardiologists and they also have family medicine. So if the family medicine provider ordered, let's say, an MRI, but now they go to their orthopedic physician within the same tax ID, but different specialty, and now they go over the MRI with the patient, that's the only exception to that rule. But other than that, if it is the same specialty, no, you can't double dip on that. So that is number 3. And then here is one of the things that I thought was kind of interesting as far as a parent. Does a parent count as an independent historian? If so, up to what age of the child? So we know it does because that's actually on the AMA grid. So a parent does count as an independent historian. And the AMA does not put an age limit on the age of the child. But the clinician must need to obtain the history because the patient is unable to provide a complete and reliable history. So put the reason that you had to go, let's say, to an older child. Maybe developmental stage is a problem, dementia, psychosis, or maybe the patient is just not a good historian. Just something that gives a reason why it's necessary to go to the parent because of the child is, no matter what the age, is a problem as far as giving information. Question 5, a patient returns to our office and the physician reviews the x-ray films done by us 2 years ago. She doesn't just look at the report, she reviews the films again. We billed for the professional interpretation 2 years ago. Can our doctor get credit for the interpretation? No, the physician may not get credit for the independent interpretation because, again, the guidelines are clear. If you ever billed for any part of that says not separately reported, any part of that test, whether it be just technical or if it's for global, then it's not credited as an independent interpretation. So please make sure that you're understanding that, because that has been the biggest issue. Is if everybody wants to get credit for something later on, and you can't do that. Now this one just came up, and actually this was also in the CPT Assistant on November. So this is CPT Assistant November 2020, page 6. And that's the publication of the AMA. Basically, they put out a publication you have to purchase saying we're answering questions, or we made a clerical error or mistake, and here's how you find it. So the question came in for me. It said, Terry, my providers are documenting just total time, not all the activities associated with it. Does this mean they are incorrectly documenting time? I don't see anywhere in CPT that the activities specifically must be documented. If the chart supports the activities, I don't see why they should have to be documented. So this question came up in CPT, and their question specifically said, if selecting an E&M 2021 office code based on time, what's the best practice for documentation? So documenting time only, or documenting face-to-face and non-face-to-face time separately. So here's what AMA CPT said. It said the E&M 2021 guidelines do not provide specific documentation best practices for reporting time. However, time must be documented in the health record when it is used for the basis of the code selection. The primary goal of documenting time is to ensure an accurate record of the actual total time spent on patient care on the date of the encounter. Third-party payers may have additional criteria regarding the acceptable level of documentation detail and should be contacted for their specifications, including delineations of both face-to-face and non-to-face time. So I'm going to give you an interpretation of that. And basically for me, they're not mandating a format which the clinician documents time, but they've also advised us to look at our MAC payers under Medicare and our private payers. And my recommendation is to use either a format that gives individual minutes per activity if you're going to time your visit, or something that says, I spent 18 minutes reviewing the records from this prior primary care physician, examining and taking history from the patient, ordering tests, and documenting in the medical record. Something like that. What I'm seeing still is people saying 50% or more spent counseling, or now that. Get away from the old language, because that's going to be a problem. If you get audited, Medicare says if they see anything that's not updated, that they will take back money, even if it's only half correct, and you don't want that. So they want you to update your information. Will all payers use these guidelines? Question 6. Yes, the new code descriptions are in this AMA CPT book, so that means that the commercial plans are on board for that. Doesn't mean that you're going to get some of the Blue Cross Blue Shields to pay attention, but let's hopefully they do that. Otherwise, that could be kind of an issue there. Okay, so here is something that comes up every once in a while, and it says, and it's always about time, isn't it? It says, if using time to select a code, this is number 7, should I document the time range or actual time? Document the actual time. Please don't document the time range, and document the activities you performed if you can, as I mentioned before. So it's just really important to make sure that you can support the time that you're providing the service. And I'm an auditor, as you all know, so I would basically, if I'm seeing a bunch of time-based codes, I'm going to say, okay, let's take a look and see how long did they spend talking to the patient's primary care provider, or reviewing the patient's history, or examining the patient, discussing treatment options, writing prescriptions, ordering diagnostic tests that they didn't also report or charge for, updating the patient medical record. I'm going to want to see all that. So, and actually be able to add up those time threshold to see where you got your information, because I'm already starting to see a flood of level 5s. And so that can be definitely an issue. Okay, number 8, it says question. I have a question on how to determine in the risk part of the medical decision making if a procedure or minor procedure, if a procedure is a major or minor procedure when assessing risk in the new E&M guidelines for office visits. Okay, so solely for the purposes of determining the level of risk for a new office visit, AMA said at their symposium in November not to use global days as we've done in the past to determine if a procedure is minor or major. Using global days would mean, a heart cath, endoscopy, and some spinal procedures would be minor procedures. So what they said is you don't have to just use global days. Obviously, using global days could be an issue as far as helpful. But the new guidelines now read, decision regarding minor surgery with identified patient or procedure risk factors, or decision regarding major surgery with patient or procedure risk factors. And so when you look at this information, your physician has to basically discuss the risk factors to the patient that are inherent to the procedure. And every patient's different. Let's say you're just going to have a knee scope, the bleeding, the puncturing, if it's a diabetic patient, tie that into the risk on a patient with the comorbidities and the condition of the patients. Those are related, but that has to be very well documented. If there could be a puncturing of the lung, if there could be paralysis. Now, if that's not things that are routine, it just happens for that patient, that's what's going to be really specific to this information. Where the procedure is done is also, and the type of anesthesia will also factor into this determination. So for example, skin procedures that can be done in the office with lidocaine, to me, that's more minor procedures than done in the operating room under general anesthesia. Treating a non-displaced fracture without manipulation versus taking the patient to the operating room to reduce an open fracture, you can see the difference in risk there. So those kinds of things you're going to want to keep in mind as you're looking at that overall risk on the patient. Now, a lot of physicians are now coding a lot of high-level services, so I'm seeing a lot of level 4s and 5s, and they're asking if they complete their chart documentation after hours, can they still include that time for total time of the visit? The reason they ask this is because if you have a 4-hour block of time and your office patient visits that day, are all level 5s, then obviously if you do the math, it doesn't work. So here's the answer to that. I can see the physician maybe adding maybe a half hour or maybe an hour of patient time at the end of their day, scheduled in the EMR, so electronic medical record, for charting. But remember, the patients over paperwork intent was to save you time. So if you're continuing to add time to your day to documentation, that defeats the purpose and could absolutely flag you for audit exposure. And if I didn't see that time blocked without a patient in that area, then I would absolutely flag the physician for that. So you have to be very careful when it comes to, kind of manipulating the situation, because that could be a definite problem when it comes to supporting that time. And we don't want you to get in trouble for that, because that can just blow up on you for, just saying, okay, well, now we're going to add time. That doesn't really make sense. So you have to be really cautious with that. Okay, so and one last question on the number 10. So this comes in and it basically, let me find it here. It says, how would you credit this data under data points? A 6-year-old patient and her mom come into the pediatrician's office and follow up from an urgent care visit over the weekend. The pediatrician notes that he read the physician assistant note from the UCC Urgent Care Center and reviewed the lab test done at the urgent care center well, and also obtains a history from the dad. Okay. Moderate data. Okay, so for moderate data, one of the 3 categories must be met. Category 1 is test documents an independent historian, and this note also has a review of an external note, review of the results of a unique test, and a independent historian. So you've met moderate on that data points for categories. So just make sure that you're counting. I know we didn't want to go to counting, but at least you're not having to count the history and the physical on some of your points as well. But those are some of the top 10 questions that I've been getting, and it's crazy some of the things that we've been hearing. Okay, and now my specialty question for the day, and this is a coding question. It says, if our provider just saw a patient who had a superficial linear abrasion that extended from below the patient's left knee to just above the left ankle, in addition to several left knee and lower leg injuries, our provider minimally debrided the patient's skin using a metal curette, but only down to the dermis layer, and then dressed the wound with gauze and compression wrap. I cannot find a code that matches what the provider has done. Does that mean I can only use an E&M or office visit code? So the answer for this is that, okay, so if you're an orthopedic or if you're in family practice, this can happen. And you have to know how to code for abrasion fixes and debridements. Sometimes the patients, will come in, suffer traumatic falls and accidents that cause injuries, cuts and scrapes. And your physician also needs to be able to support those. So you can't code for the wound debridement codes in the 11042 to 11004 section of CPT because those describe depths that are, subcutaneous muscle and fascia. Sometimes they even go down to the bone, and your physician didn't do that much in the encounter. So to describe your physician's work, your provider's work with this, you'd want to look at code 97597, debridement, high pressure water jet without suction, sharp selective debridement with scissors, scalpel or forceps. It's for an open wound, and it just talks about devitalized, skin or dermis. And basically it also says including topical application of a wound assessment. And so that can be very helpful. Again, that's the 97597 code. So you don't have to go just to the E&M service. And if it's more than 20 square centimeters, you would have another add-on code 97598. That's the one thing, though, that your physician has to keep in mind. They have to make sure that they're giving surface area. So make sure that you're putting in the measurements when you do any kind of debridement, any kind of wound closure, anything like that. Otherwise, it can be a problem as far as capturing the service. Our coding question is brought to you today by Medical Economics, smarter business, better patient care. Follow us for the latest news and viewpoints on primary care, specialty care, and industry happenings in the business of medicine and health IT. medicaleconomics.com. You also want to check out my article in the January issue, so it's this month, and that was on leveraging the AR in a physician's practice. And I'm also being interviewed today, actually, the February issue of Medical Economics and the future of telehealth. So that is going to be quite the discussion today, I'm sure. So I wanted to end with a personal tidbit this week, and I've been updating my website to be more in line with where I live in Southern California. I love palm trees. I even have a palm tree necklace, but also adding some additional partners to my partner page because I've been really collaborating with a lot of friends and vendors that are also in the industry and just trying to make things not a little more personal, but a little more me. So if you get a chance to look at terryfletcher.net, if you haven't been there in a while, I'm going to be adding a giving back page as well. Just let me know what you think. I'd love to get a DM from you. My website designer, who's also my podcast producer, Joe Kuzma, he did a great job. And if you like the photographs of around my city, there's some of the beach, some just of my town where I'm at, my local photographer and actually a very good friend of mine, Nick LaCroix, he is actually on my partner's page as well. So you can find their information if you're interested in any of those services. Also, when I mentioned the Giving Back page, I wanted to challenge everyone to see if there is a charity or need out there where you can donate or give your time, or, with a mask, of course, or if you have extra funds that somebody else doesn't, because, it's still, the health emergency is still out there. Just an example, and I'm just saying this so you can see what you could do if it's something that you can afford. Both of my stimulus checks, I donated to food banks because I did not need them. And that's the problem with stimulus checks, is that it's kind of blanketed for anybody to get them, and not everybody needs them. And if you fall in that category, try to make sure that someone in need gets it. There's kids that are still in online school and aren't getting to eat during the day, and that really drives me crazy. But you'd be paying it forward, and that's what we're all here for. And that's what's going to get this economy and everything, just open back up. So let's see if we can do that, if you have the ability to do it. And it's not just about money, it can be about time as well. All right, everyone, make it a great day and a great week. And thank you for listening this week. And I'll talk to you next time on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.